But really, when I think one of the topics today was about what is cancer and how do you get it and how can you stop it, all that sort of stuff. I think that really, if you think that our cells and our bodies, are made up of millions and millions of cells, and they constantly regenerate, which is a bit what this circle here is over here. And every time your cells regenerate, the DNA changes over. It's like rewriting the Bible, or like the monks used to do, painstakingly, page by page. Every time your DNA replicates, there's a chance for a mistake or a mutation to occur. And a lot of those mistakes, you can often recognise a word with a spelling mistake, you still know what the word is. Sometimes if that mistake is in the wrong place, it changes the whole meaning of the word or results in a very different outcome than what was intended. And so when normal cells mutate or develop a mutation, one of the potential outcomes is that it will become a malignant or a nasty cell that instead of doing what it normally does, it will do damage to you and whatever organ it's in. And so really that's what's actually at the heart of all cancer. And we will talk about things that influence this, but the main thing that influences all of this is actually age. So the more times all those cells turn over and replicate, the more chance there'll be a mistake, or the more chance a mutation will come, and therefore the higher the chance of a cancer developing.
Oh.
And so really that's why the commonest risk factor for all types of cancer is age or getting older. And there are other things that will influence as we talk about, but that's what's sort of at the root or the base of it all, if you like. And luckily our ability to understand all that has changed in the last, certainly in the last 50 years, but it actually really in each decade of the last years, we've made huge advances forward. And so that's a good thing. Another way to look at the outcome of that DNA change is if you look on the left of this slide, and we said, here's, if you like, the lining of your GI tract, so your esophagus or your bowel or your stomach. Normally, there'll be one row of cells that all look pretty happy, like this. But when a mutation occurs in just one cell, then often it will start to grow more than normal. This might be called hyperplasia. And then it will start to grow abnormally, and the cells will start to look a bit different to normal, to all these other sort of regular cells, and grow in a haphazard, untoward manner. And that might then lead on to something some of you might have heard of called in situ cancer, or often called precancerous change. So for in the breast, we might call that, you might have heard of something called DCIS. But this is a group of cells that are definitely abnormal, and that technically those cells, the purple ones there, they are cancerous. But because they're still stuck in here, they haven't turned into what we call a cancer. That's the next step up here on the far right, where the abnormal cells are now invading through all the tissue and indeed can get into this thing down here, which is a blood vessel. And once a cancer can do that, then it could spread anywhere in your body. And that's obviously the part we want to avoid if at all possible. So a lot of cancers we can catch when they're like this, in situ, and they're completely curable. When they get to this stage, often we can cure them because we can get them before too much has gone into the blood vessel, or indeed none at all. But sometimes if we're talking about people with more advanced cancer, stage 4 cancer, for example, that's when nasty cancer cells have penetrated through the local tissue, got into a blood vessel, and gone off to land and live and grow somewhere else like your liver or your lungs. This is just another way to represent that along the top. Instead of it just a line of cells, I've made it into a circle or a tube, because lots of the organs in our body are set up like this. And so when, this is an example from prostate cancer, when things are stuck inside that tube or that lumen, then we've still got in situ disease or curable disease. As it starts to break out, that's when we get into more trouble. And really the red part down here is probably a bit of what we wanted to talk about. When people say, well, how does stress and radiation and too much sun, how does that all affect the chance of me getting a cancer? So if there's a change in your DNA or a mutation, all of these things, so inflammation, oxidation, signaling pathways, all sorts of things can affect the chance that all of these steps will be taken. And so as our ability to treat cancer has gone along, we've found ways to intervene earlier and earlier to stop all these things happening. Because really, where my arrow's going up and down now, if we can stop anything on this side of the line, then really we would say then we would be able to cure the cancer, in inverted commas. But when it starts to spread elsewhere through your bloodstream or your lymph stream, that's when we have harder trouble. This is just to remind me that cancer affects all ages, but there is a difference between what happens in men and women. So on the left-hand side, the yellow stuff, that's all the incidence of male cancers. And on the other side in the blue, that's cancers in a lady. And not surprisingly, down here you find that in a lady over 20 or between 25 and 60, the commonest cancer would be breast, whereas in a man, the commonest cancer would be prostate. Interestingly, you'll see bowel cancer comes not too far down the list in both men and women. And there are some things that are obviously a bit more specific, like ovarian cancer. Melanoma gets up here on a big line in men. It also affects a lot of ladies when they're younger. So pardon this picture, but it's important to just show you how things have changed. Back when we started treating cancer, sort of throughout the first half of the 1900s, we thought that more was good. We did terrible operations on people. And now we've got to the point, pleasingly, where this is a much more common result for someone who gets breast cancer, that their breasts are able to be left intact and hopefully look symmetrical and the same. And indeed, a combination of all these other things, radiation, chemotherapy, hormonal therapy, and some other targeted things we're going to talk about, now mean that this type of patient, who we still see today with a very nasty tumour that's come through her breast, we can actually get her back to this sort of point in a lot of cases. We certainly don't have to be doing this type of radical surgery as we did before. So the good news for all of us in this room is that this is just some figures on the incidence and mortality of cancer overall. These are all Victorian figures. If you go over here, although it cuts off here, this line is most important. That is the line that says the mortality or the death rate from cancer of all types in Victoria has been going steadily down out until 2020. And in fact, since we started recording this stuff reasonably back in the late 1970s and early 1980s, the mortality from cancer has dropped by about 40%. You know, that's an amazing achievement in only 20 or 30 years. You'll notice that that incidence or the number of cancers that we see has actually been going up. And that's a factor of people of all people living longer, so more time for cancers to develop. So here's just some quick stats. The incidence of breast cancer you'll notice that about 25% of all new breast cancers occur in ladies under 50, 75% ladies over 50. So when I said before that age was important, that's very true. Most breast cancers will occur in women as they get older. But we know that there are also women who get quite nasty DNA mutations much earlier in life. And this is where you hear about the gene. The gene itself will make a cancer occur. So BRCA1 and BRCA2 are genes that fortunately only about 2 or 3% of all women carry. But if you have them, there's a very high chance that having that gene or that DNA alone will cause you to get cancer. Whereas in the older ladies, generally speaking, the cancer will come not just because of some dodgy DNA, but because of a number of other environmental things, like whether they smoked or not, how much alcohol they drank, when they had their first baby, whether they breastfed. A whole lot of those sort of environmental things can influence the chance of these mutations becoming a problem. Now, this is just to reassure you, because if you listen to the breast screening people who do a marvellous job, but they'll tell you all the time that there's a 1 in 9 ladies will get breast cancer, and that's true if you add up everybody, even when they're 105. But there are a lot of patients who get breast cancer when they're quite old. So actually, if you took most people, say, let's look at a lady who's 40 years old, her chance of getting breast cancer isn't 1 in 9, it's actually 1 in 70. Obviously, it gets lower as the older you get. But really, it's not nearly as prolific as the media would have us believe, which is a good thing. Now, we wanted to talk a bit about why breast cancer develops and can you prevent it. So we know now that when the tissues or the cells in your body become inflamed, which they might more sedentary lifestyle you lead, that means there's an increased chance of these mutations occurring or advancing further down the path. So if there's a message here, and there are a couple of messages, one of them is that exercise definitely decreases inflammation, usually leads to burning off more fat, and certainly leads to less chance of getting cancer in the first place and less chance of it coming back if you've had a cancer. And when I say exercise, I don't mean running off to the gym and bench pressing 500 pounds every day, although you're very welcome to do that. This stuff's all based on walking about 30 minutes a day, most days of the week. That type of exercise will definitely decrease your chance of getting cancer, as will a diet that has more fruit and vegetables or plant proteins than an excess of animal fat, if you like. So that's, to be clear, when we're talking about diet, we really need to talk about moderation, and that triangle, that food triangle we used to, or food pyramid we all used to learn about back at primary school, that's still important, because a balance of everything is what's needed to make that DNA, to make all those cells replicate as normally as possible. So whilst plant protein is good, no meat or no animal protein is also a bad thing for you. It causes different types of problems. We know less weight you carry, less chance of dying of all sorts of things. And this is probably going to turn out to all be to do with what sort of inflammatory state your body's in at any particular time. So in fact, as some of you who have been around as long as I have will remember Norm and Life Be In It was a campaign well before its time, because the more you're out of your chair and taking a walk around the park, probably the only thing you can do in COVID times, the better for your overall health, but certainly the better for decreasing your chance of cancer. Other lots of good things have happened, because although this picture is a bit blurry, this picture on the right here is a mammogram from about 1980. And you could see, you probably can't, even allowing for the projection, you can't see too much in that picture. Here's a mammogram that we might see today, far more easier to read. And indeed, here's the type of stuff we get routinely today called digital mammography, where you can enhance various bits of it all the time. There's a little cancer hiding in there, that sort of blob in the middle, easily detected by the radiologists with the type of kit they have these days. And this type of cancer in a breast is completely curable. So here's a slide I wrote a long time ago in 2005, when we said, we were still doing a lot of mastectomies, we said what we'd like to do for all cancers, in this case breast cancer, is only have to take the lump out, to only do something called a sentinel node biopsy rather than take all your lymph nodes out, which is what we used to do, to try and give you radiotherapy treatment in one day, all as part of one operation. That any other treatment we gave you, like chemo, was quite targeted and tailored to each individual lady, and that we made sure we were causing very minimal long-term side effects, because the aim of the exercise in cancer is to put you not necessarily back to normal, but leading a life that you are enjoying, is full, and where you get to do most of the things you want to do. So what we really want still is better survival and less stigma associated with it, and the treatment to be easier and less invasive. And so largely today, in 2020, most women, for example, who come with breast cancer will get away with a lumpectomy, a sentinel node biopsy, but even that will probably go soon. We're giving the same benefit from radiotherapy, but in less and less doses, sometimes in a single dose. And we're getting much better at what we do with chemotherapy. So this is just a few lovely pictures about what we can do. So when I started out, these machines for sentinel node biopsy were very important. And even though they were a major step forward, because it meant we were only taking out 1 or 2 lymph nodes instead of 20 or 30 lymph nodes and causing swollen arms or swollen legs left, right and centre, probably before I finish my career, these machines will even be obsolete, because we've got smarter and smarter about how we stage cancer and detect what it can do. So that's a picture of a sentinel node probe, and that's about the size of my index finger, that piece of machinery just there. And that shows you how minimally invasive surgeries become. We're not going to talk too much about that. Here's where I think we might hopefully get with radiotherapy at some point, but you can see how long things take to come. This case was done back in 1998. This was a lady who'd had her breast cancer taken out from her breast. Just there you can see her nipple. Instead of having 6 weeks of radiotherapy, she had a single dose delivered by this device here while she was asleep on the operating table. When she woke up, that was all closed up. This is the thing from afar. That's her arm sticking out there, and her breast is in here. That study is actually just published, again, the reason I put it in today, about 3 weeks ago, the long-term results of this study, saying that this type of technique for most women with breast cancer was just as effective as 6 weeks of radiotherapy. Obviously, if you come from the country, that can change materially the way things happen to you. So we said that back at the start that we were looking at those cells and how the DNA in it might change. And we've now finally got to the point where we routinely look at the DNA in tumours, and that's what this slide here is about. Some of you might have heard of this test called Oncotype DX, which is used in breast cancer to predict whether or not ladies would benefit from chemotherapy or not. And so it's really the first precision medicine test used to say to a large group of ladies, in this case, all these people who fall into these green boxes down here, that they will not benefit from chemotherapy, and therefore we wouldn't put them through it. Whereas another group, let's say in the red area here, they're showing bad DNA, if you like, stuff we know that's associated with the cancer spreading, and where the benefit from chemotherapy is much greater. So the whole treatment can become more targeted. These graphs just show that if you have a good score in that thing, we know you're going to do well and we can give you less treatment. Whereas if you have a poor signature, that's identifying ladies who we should be subjecting to chemotherapy, because we can show better outcomes. So don't get too fussed about all the graphs. Luckily, these tests now are becoming much cheaper than they usually were. So the standard test for that type of thing we were just mentioning now in Australia costs about $2,400. And just like the cost of your TVs goes down and down and down, when the newest model comes out, it's $10,000. Within a few years, it's down to $2,000. The same thing is happening with gene testing. So in the not too distant future, that type of test will only cost something in the region of $500. It will be rebatable, And instead of us having to fight for it, everyone will be getting it routinely. So chemotherapy, I just wanted to mention that most of the time we're trying to give chemotherapy for cure. So we're trying to wipe out any cells that might be left behind after surgery or radiotherapy. And palliative is meant for chemo that's just trying to slow something down. These next two words, what we've done for a long time is give chemo after we've done some surgery or got rid of the tumour, and trying to mop up, if you like, what might be left behind. But many of you may know, if you've been treated recently, that we've changed things around again and are giving more of what's called neoadjuvant chemotherapy. And that means chemotherapy first, so we can see firsthand what's happening to the tumour. So instead of operating on a cancer first, we might give some targeted treatment first with the best drug we think is around. And if that shrinks the tumour, that tells us a couple of things. One, that treatment is working. It often predicts better outcomes for those patients. And it means often that we can do less surgery and less radiotherapy in a lot of cases. You don't have to memorise all this, although there will be a test on this later. This is just to tell you that there are lots of different types of chemotherapy, and over the last 50 to 60 years, all of them will have been tried in all sorts of cancers. And the reason why, because I often get asked, why don't you try, my friend had this for their cancer, why don't we try Taxol, or why don't we try platinum in my case? And the answer usually is because long ago, these things were already tried against all sorts of various cancers, and if they were found to work, we would still be having them. But if they were found to do no good against that particular cancer, then we would have wiped it out of wasting people's time. So often you get asked, where does chemo come from? And like a lot of science, the main answer is by serendipity. People have found, when they've been looking for other reasons, that these drugs will kill off rapidly growing cells. And cancer cells, compared to everything else, are generally very rapidly growing. And that's why we want to use drugs that will attack them at that particular point. So often their greatest strength, so they're growing fast and can spread quickly, is also their greatest weakness, because it's when this group of drugs in particular will work best against them. Of course, the big pharma companies have been doing large-scale drug screening of all sorts of things for years and years, and that's how a lot of the types of chemotherapy we have now have been found. And that's been done by looking at bacteria, and indeed some things that we now commonly call chemo actually started life as various forms of antibiotics. But there's lots of stuff that comes out of plants because there are lots of not naturally occurring toxins which we've turned to our advantage and synthesised into various forms of chemotherapy. So we're not going to talk too much about the way chemo kills lots of cells, but all of those slides just say there's lots of work. The simple premise behind it all is that if we went to that cell and said there's damage to the DNA, that's when you get mutations and that's when you get cancer. A lot of these agents are trying to repair any DNA damage that's been done or stop it from replicating or continuing. And so this is why some chemo agents will work on some tumours but not on others, because they have particular types of DNA changes. Conversely, it's why ultraviolet light, if we're talking about melanoma in particular, can affect your DNA in various ways, and that's one of the reasons why you might develop melanoma, for example. This slide's just to remind me that, like a lot of human endeavours, we often go by the principle that if some is good, more is better. So a lot of the times now people will get two different lots of chemo that are attacking the cancer cells at different places. Sometimes they're attacking the nucleus or the brain of the cancer cell, but other times they're attacking the outside or its outer defences, because if you can breach them, you can often kill the cell. So, God knows how long I've been talking for the last few minutes, Esther, but this is to remind me to shut up and make sure there are no questions.
All good. We're still at 2:30. We're good.
So I might got another few things just a bit about melanoma and about how that might affect things, and then we might stop for questions. Is that okay?
Yes, that's okay. Sorry, I was unmuting myself.
All right. Hopefully that's all right with everyone else. Hopefully it's not boring. So here's a slide I love and have used for a long time, because really it's where we're trying to go with all cancer care, not just chemo. But really, I think, as probably some of you know, chemotherapy is a pretty toxic thing, and it's like trying to kill the cancer with a shotgun. Whereas luckily over the last 20 to 30 years, we've got much better at using sniper bullets. So hitting the cancer in one spot right where it hurts and where it does minimal damage to the rest of you. So when we talk about targeted therapies, that's really what we're talking about. So some of these things work on their own, but some of them will add to the benefits we can already get from chemo. Generally speaking, the real benefit of targeted therapies is that their toxicities or the side effects are very specific, so much more minimal than chemotherapy, which is a good thing. Why are we interested in targeted therapies? So here's a PET scan, an early PET scan of a patient with metastatic melanoma. Most of those dots, those black dots, are deposits of melanoma all through that person's body. Here's the same person a few weeks after some targeted therapy. This change has occurred in only weeks, not months and months of chemo, but about 6 weeks of treatment. When you see that sort of scan when you've been dealing with cancer for a long time, you really sit up and take notice. So a lot of these drugs we're going to talk about for a couple of minutes now are called monoclonal antibodies. All that really means is that they're targeting specific little bits of the cancer cell, specific little receptors. Often we might call these things ignition switches on the outside of a cancer cell, that the drugs can come on and turn on or off. And just like the ignition in your car, if you turn it off, it won't go anywhere. Same idea with the cancer cell. If you turn some of these switches off, the cancer cell will stop growing, stop mutating, stop spreading, and die off. That's the aim of the exercise. When we're only targeting one little switch, then the chance it will cause trouble to the rest of you, make your hair fall out, make you feel sick and terrible, nausea and vomiting, all those things plummet off into non-existence. So the first one of these drugs was called a BRAF inhibitor. One of the other great things about this was it's just a tablet. Here's the patient, and this time at the top. That's the big thing in the middle, that sort of triangle. That's their liver full of secondaries or metastases, which on these scans are those big red yellow. Here's this patient after just 2 weeks of tablets, BRAF inhibitor tablets. All that stuff in their liver has just about disappeared. See, all the active stuff in there has gone. Even the lumps in their liver have got smaller from these CT scans. But this is the type of thing we're trying to do in cancer care now. We're not all the way there. This is just another example of that with a drug called imatinib or Gleevec, which similarly has turned a great big tumour like this. This is actually down in someone's pelvis. You can just see the bones of their pelvis there. Like this, 4 weeks later, to only this. So massive change, again, with just a tablet. This is the front page of The Economist, a well-known magazine. A long time had surgery, radiotherapy, chemotherapy for cancer. Then along came the targeted therapies, which we talk about, those sort of agents just switch particular bits of the cancer cell off. And the newest player around is immunotherapy. So some of you might have heard of something called IPI. The other thing is something, this is just an example of how well that works. So we used IPI first in melanoma, the first form of immunotherapy. It unfortunately does have some toxicities, but certainly changed the lives of many patients with melanoma. So now look at how the whole immune system works in the development of cancer and its progression. We know that early on when a cancer is growing, so these red cells down the bottom here, it's hiding from your immune system. It's been able to make itself invisible. But when we can use drugs like IPI and PD-1 inhibitors, then all of a sudden the cancer exposes itself to your immune system, which then can attack it and knock it off. And of course, not surprisingly, your own body is quite better at doing this than all those drugs we might have mentioned before. So a tumour will be growing when it's hidden from your immune system. But once your immune system can see it, then we have a chance of either eliminating the tumour or keeping it at that early stage we were talking about way back at the start of this talk, where it's in situ disease or where those cancer cells haven't been able to spread anywhere. This is actually a picture of an immune cell or a T cell attacking a cancer cell. And this funny circle or crater here is like one of those ignition switches we were talking about before. Now we've taken the brakes off the immune system and allowed it to attack cancers. So a whole new string of treatments have come. The main two drugs you'll hear about are volumab and pembrolizumab. And that's some trials showing the great benefit that they have. And here is the side effects these things cause, much less. Only about 15% of all people who have immunotherapy get side effects, and most of those side effects can be pretty easily with steroids. So not only are we seeing much greater survival, so in melanoma, stage 4 melanoma, survival went from about 5% at 2 years to 60 to 70% survival at 2 years with the advent of these drugs. And in most patients, that's been changed into long-term survival for about 50% of patients, way up from the 5% it used to be only 10 years ago. So really, immunotherapy we're only at the end of the beginning. You might have heard about CAR T cells. CAR T cells are the next wave of immunotherapy, if you like. It's coming. It's also already showing great results in blood cancers like leukemia and some forms of myeloma. And hopefully soon we'll see showing really great results in solid tumours like lung cancer and pancreatic cancer. The good news about this approach, as opposed to immunotherapy, where most people will be on it for a good length of time, is that CAR T treatment is generally a once-off treatment. So one treatment cycle only, not repeated cycles to try and get them. So not only treat the cancer you have, it also, the idea of it is it also immunises you against getting that cancer again in the future. Peter Mack's lucky to play a major role in the Southeast Asian region in the production of CAR T therapies. We've invested in it for over 20 years because we believe it would be the way of the future. And so now we're really one of only 3 centres in the world capable of actually producing these CAR T cells on a mass scale in our own facility. And, no talk is complete without a stop with the new back in the air with the very important bridges into the Royal Melbourne. With whom it's fantastic that we're able to partner to provide all the other supportive services we never really had when we're on our own in Melbourne. I won't point out, if you look at the size of the Royal Melbourne and the size of Peter Mac, what might look bigger. It's probably just a figment of your mind. These just shows that the number of melanomas is going down per year, which is good. Still wanted to remember that when we're talking about how we can prevent cancer or do anything about it, early detection of melanoma is still critical. And this is just to remind you that if you have a mole that looks asymmetrical or has got a funny border like the coast of Scandinavia, or it's got funny colours in it, or it's getting bigger than the end of your pen, then you should go see your doctor about it. Luckily, even simple tools like this are making the diagnosis of melanoma come about earlier and earlier. Most GPs would have one of these things in their office all the time now, and with telehealth, they can either take a picture on their mobile phone and send it straight off to the dermatologist, making the detection of these things much quicker. That's just a couple of pictures of what a melanoma looks like down one of those pieces of kit.